Okay, so we're now recording. Let's go ahead and finish up the bugs and drug stuff, and then we'll finish move into derm, see how much we can get through, and then I'll have to maybe modify the test a little bit to see what we actually get covered here today. Anyway, so any questions from last time? All right, so looking at fluoroquinolones, it's a very overused set of antibiotics, unfortunately, but has a lot of good utility. The way that it's going to be working is basically by inhibiting this enzyme called topoisomerase. What that does is that normally that enzyme, when you think of DNA, you think about it being this really tightly wound double helical structure. In order to do things like transcription, translation, all of that, for that to occur, you have to unwind that DNA, right, to allow for those base pairs to kind of relax, and then they can do their thing. Well, topoisomerase does that. It causes single-strand breaks that allows for that unwinding to occur. If you inhibit that, you prevent the unwinding from happening. You also prevent it from rewinding. So you see these strand break kind of errors that occur. Again, once the bacterial DNA the bacterial cell determines there's too much damage done to the DNA, that's when apoptosis will kick in and will kill off the cell. Okay. These are good drugs of choice they have a wide range of activities. So you're going to see really good gram-positive, gram-negative activity. A lot of these will cover Pseudomonas, right? We'll find that of the bunch, you're going to find that ciprofloxacin probably has the spottiest coverage, but in general, like levofloxacin, things like that have very good coverage against that. Does not cover MRSA though, even though it does have pretty good gram-positive coverage, does not get MRSA, okay? Other things that we'll cover atypicals, which is again why we like to see it for a lot of like pneumonias and things like that. So for instance, community-acquired pneumonia, see it used pretty frequently, UTIs. Now there is one exception with UTIs. We do not use moxifloxacin for UTIs. The reason for that is that all of these are going to be renally eliminated, so they can go and concentrate in the urinary tract. The exception to that is moxifloxacin only gets eliminated in the liver. Okay, so no moxi for UTIs. Other things, infectious diarrhea, whatnot. Now, as far as interactions go, this has the same sort of interaction as the tetracyclines did, as far as it will chelate cations like iron, calcium, things like that. So again, that could limit the absorption you have. Other things to note, these will prolong QTC, right? So again, remember that's a problem, especially if you have multiple drugs on board. Prolonged QTC, you can see what arrhythmia.
QT prolonged.
Right, what arrhythmia can that lead to? Torsades, yeah, torsades is the big arrhythmia you worry about, QTC prolongation, right? In the elderly, you can see some CNS effects, so again, sometimes it may be good to avoid it with them. They also tend to have more of the renal issues, so they can accumulate levels, which can lead to some problems. And then, of course, like we saw with some other antibiotics, if you interrupt the gut flora, you can interrupt vitamin K absorption, and that can interact with a vitamin K antagonist like warfarin. Okay. Yes, ma'am.
So every antibiotic, could they end up interfering with the contraception, like the birth control?
It's a theoretical risk, right? So anytime you're messing with the gut flora, obviously some of them are going to be worse for doing that than others, especially those that have a lot of like anaerobic coverage, like that's why we see more like C. diff with clindamycin, things like that. So there's a theoretical risk for all of them.
So that means that all of them will also interfere with with blood thinning
to varying degrees, so again, it's all kind of on a spectrum. Now, for instance, one we'll talk about in a minute actually has a CYP interaction that really jacks up your INR when you're on warfarin, but this is going to be something more to do with the vitamin K absorption, right? So again, to varying degrees, always be careful when you have a patient with warfarin. We'll talk more about that in the heme section later on, so kind of just keep that in the back of your mind, right? A lot of overuse, just like the macrolides get a lot of overuse for a lot of upper respiratory tract infections and pneumonias. So because of that, we see a lot of resistance. So we like to hold off on these if we can and try to use them as like alternatives if other agents aren't going to work, or if we see some resistance to kind of more first line sort of agents. Okay, C. diff is another big concern, just like we see with a lot of other antibiotics. The main agents you're going into, they have different generations. This is less necessary to kind of keep the different generations in mind, like the cephalosporins, like those you really want to keep separated because their coverage is so different. Here you're going to find it's a little bit more of a blend, so just kind of know, I just kind of showed them in different generations to kind of see how it kind of progresses as time has gone on. But one of the big ones we had was Cipro, or ciprofloxacin. Most people have probably heard of this one. This gets used a lot for like infectious diarrheas, a lot of sometimes used in combination with other meds for gut stuff. But again, watch out for that renal dosing. You have to adjust for that, otherwise it can really accumulate those levels, can be a big problem. Okay. Again, this one has plus minus coverage for Pseudomonas, so you can find the resistance maybe more likely with this one than some of the other ones.
I guess I'm kind of confused because like in ClinMed and other places, I always see Cipro being used a lot more than Levaquin.
Mm-hmm.
And but levaquin has better pseudomonal coverage.
Mm-hmm.
How, and it seemed like the infections were pseudomonal infections.
Mm-hmm.
Why is that?
So what type of infections? Like, that goes back to the question, what's the context, right?
Yeah, because Septra is used a lot in like UTIs,
Mm-hmm.
right?
Right. So how often, the question is, are you worried about Pseudomonas UTIs?
Oh, okay.
Typically not very commonly, right? You think a lot more like enterogram negatives like E. coli, Proteus, things like that, where Pseudomonas is unlikely to occur there unless you have like a lot of medical comorbidities, a lot of frequent UTIs, maybe a catheter is in place.
Or even like in eye stuff too. That's where.
Yeah, so the eye is another big.
So pseudomonal coverage with
Yep.
people that wear lens.
Mm-hmm.
Why would they use Cipro when they could use levaquin?
Mm-hmm. So the answer to that goes back to concentration, right? So resistance is all a matter of how high it can drive up the concentration of the drug or how high it gets at the site of action. So systemically, I can kill off any bacteria with enough antibiotic, but it probably will hurt the patient as well. So I don't want to do that. However, if I'm applying something topically, say for instance to the eye, where I can get very high concentrations locally, I can overcome that resistance very easily, right, without really causing a whole lot of harm to the patient. And that'll come up again when we get to ophtho a little bit later on, for sure. A good question though. Levaquin is going to be a pretty good workhorse as far as fluoroquinolones go. Use it very frequently, a lot for like hospital-acquired pneumonias or nosocomial pneumonias, mainly because it has good pseudomonal coverage. And remember, when we said when we're double covering for pseudomonas, what's the thing you want to think about? Complementary what? Mechanisms, right? So a beta-lactam plus a fluoroquinolone, an aminoglycoside plus a beta-lactam, something like that is a very common combination, which is why you see this used pretty frequently in that case.
So,
yeah.
In the previous PowerPoint, you were saying for Pseudomonas, you want to do double coverage.
Mm-hmm.
Is that always the case?
Generally, yeah. If you're really worried about because it is such a serious bug when you run across it, that you want to make sure that if one of them was resistant, you at least have another backup that's going to be treating that, or they can get some synergy there by working together in those cases, right? But again, that's not the rule. Generally, you do not want to double cover most bugs, but Pseudomonas is one of those things where you do want to do that, right? However, for like an eye infection, again, we're getting such high concentrations there, you don't have to double cover for it, right? So again, it all depends on the context and what you're talking about, okay? Anyway, again, renal dose adjustment. Watch for this because, again, you can see if all of a sudden your patient who's in the hospital starts, elderly patient, they start to get a little wacky. Is it their dementia? Is it the fact that they're sundowning? Is it the drugs we're giving them we're not adjusting for renally? Oftentimes you can try to isolate these problems, see what exactly is going on here, right? So again, we don't want to be the cause of their altered mental status in those cases, right? Now, moxifloxacin, as I mentioned, does not get used in UTIs because it only gets metabolized in the liver, so the concentrations would never be high enough in the kidneys to actually treat a urinary tract infection, right? It just doesn't get eliminated that way. But has very good coverage for other things. You see this used a lot in pneumonias. You see this used a lot for ophthalmic or otic purposes, so you'll see that used quite frequently from that case there. Now, again, I mentioned the issues with fluoroquinolones. They'll complex with those cations, so you got to watch out for that as far as absorption goes from a dietary sort of standpoint. Other big things to watch out for as far as drug interactions is inhibit CYP1A2. This is much less clinically relevant than a 3A4 interaction, but it still can come up. So again, if you're not sure, just run an interaction checker and find out what's going to be interacting there potentially, right? Again, majority of them are going to be renally eliminated, not moxie, but the other ones certainly will be, so watch out for that. Torsades is an issue. And then the other unique thing with the fluoroquinolones is this idea that it can cause tendinitis and then potentially tendon rupture, right? So the Achilles tendon is one of those things you classically think about with this. Again, we don't have a good mechanism for why it occurs. We have no idea. It's just something you want to be worried about, or at least to think about. So people will say, hey, especially in younger patients, they say less than 18, be careful with using fluoroquinolones. We'll still use it occasionally, right? It's a relative contraindication, but in general, if you can avoid it, go ahead and avoid it, right? It's not like doxy where if they're less than 8, you definitely don't ever use it. We'll still use fluoroquinolones in kids less than 18. You just want to be careful, educate them that they're saying like, oh man, my heel's like really killing me and it feels like I ran a marathon, I didn't do anything yesterday. That's a bad sign. You want to be aware of that and make sure you get them off of that and onto something else, okay? Okay, up next with clindamycin. Oh, yes, sir.
So I don't know if you mentioned the concern over the cation stuff, or like the other one are fine with the calcium or whatever.
As far as like with the tendinitis?
No, it's just complex with cation.
Yeah, that's the iron calcium thing we were talking about before, right?
Is that associated with tendinitis?
Not that I'm aware of. I'm not sure about that. I have seen some varying biochemical hypotheses about how it happens, and nothing really seemed that convincing. So we just know that it happens, and just to watch out for it, right? Yes, ma'am.
On
On some of the slides, it'll say like plus minus or plus or minus Pseudomonas. What is that?
Plus minus means that it could have some coverage, but it's more likely than not to be one that it's like if you're going to see resistance pop up, it'll be to that one first, probably, right? So again, for some cases, you may find that has good coverage for a particular strain. You go to the next patient, the next room over, they have a different strain, and it'll be totally resistant, right? So again, it's one of those things where it's more spotty as far as the susceptibility goes. Whereas with Levaquin, I'm more likely to get a consistent susceptibility with multiple strains of Pseudomonas. Okay, so that's why if I had someone who I knew had a pseudomonal infection, Septra probably wouldn't be the one I'd jump to first, unless it was a case for like an ophthalmic purpose or something. But Levaquin is going to be more consistent with that, right? But again, if I already know it's Pseudomonas definitively with a culture, I have the sensitivities to go along with that anyway, and so that will tell me what's going to be resistant or susceptible to. Okay. Say that again. Again, all depends on the susceptibility. Typically, Levo and Moxie tend to retain better activity than Septra will, generally speaking. Yeah. Up next, we have a different. This one's kind of a one-off sort of class of drugs. It's called Clindamycin. It's another protein synthesis inhibitor similar to the macrolides, but it kind of fits in its own little unique category here. This has very good coverage against gram-positives. It has very good coverage against anaerobes, and that's it. Okay, so no gram-negative coverage you're going to see here with Clinda. In fact, it shares a lot of similar properties as something like vancomycin, but the additional benefit of having anaerobic coverage. Okay, so again, if you want gram-positives, anaerobes, this is a good drug. So for instance, I mentioned before, for like a dog bite, you're worried about skin stuff, you're worried about stuff in the animal's mouth, right, which are going to typically be anaerobes. You'll use something like augmentin, which is amoxicillin plus a beta-lactamase inhibitor like clavulanic acid. If you had someone who's really allergic to penicillin, you could not use that. This is a good backup because, again, what does it cover? Anaerobes and gram-positives, right? Now, if there's any gram-negatives that might have been around the mouth, I won't cover that. However, it could be a good alternative. So you'll see Clinda use it frequently for pen-allergic patients potentially, okay? Again, this is a good choice, especially if you have, this is actually interesting because it will bind up endotoxins that certain bacteria can release. So if you hear like toxic shock syndrome, oftentimes the patient gets so shocky because of these endotoxins that the bacteria are releasing. This will actually bind those up. So you may see that we're not using it to treat the bacteria, but to treat some of those toxins that are being released there. Used very frequently for skin and soft tissue infections, which we know typically are gram-positive infections, right? Osteomyelitis is a big one. And I mentioned sometimes surgical prophylaxis if they're really pen allergic and you could use a cephalosporin. And then very frequently we use it as an intra-abdominal covering drug, but we'll typically use it in addition to something else that will cover gram-negatives, right? Because this one won't provide any coverage for that, but will hit the anaerobes. This one has the most association with Clostridium difficile. So again, C. diff is a big concern with this one. Again, if they get really nasty diarrhea from this, like that could be concern for having a true C. diff infection. So be careful with that. Other than that, very well tolerated for the most part, not a lot of issues you see with this drug here. And again, that pseudomembranous colitis is something that C. diff can develop into. It's kind of the more severe form of one of those infections there. So that's all that really is. Up next, again, you kind of see these are like the one-off sort of drugs here. Next, we have sulfamethoxazole and trimethoprim. This is a combination drug. Bactrim, Septra, a lot of people have probably heard of it before. This one actually has a complementary mechanism built into the combination, and they both work to prevent the bacteria from utilizing folic acid. Okay, folic acid, if you're aware, is used to produce things like nucleotides for DNA synthesis, right? And so if I can inhibit that by inhibiting two steps along the pathway, they can't utilize this. And again, actually, this is very similar to how the drug methotrexate works for things like cancer, rheumatoid conditions. We'll talk about that later on. But basically, by inhibiting folic acid utilization, they cannot produce new DNA. Again, DNA damage leads to apoptosis. Okay, so again, looking here, the sulfamethoxazole is going to inhibit this PABA enzyme, or actually the conversion of PABA into dihydrofolic acid. So you can see that first step here being inhibited, and then from dihydrofolate over to tetrahydrofolate, this is where the trimethoprim is going to fit in and inhibit that, right? Now, have I shown you any dosing examples using Bactrim before? I think I did in like the intro to pharm class last semester. Now, again, remember whenever you see a combination drug like this, you're dosing off of one particular component. So again, when you're looking at your dosing, be careful with that. Make sure you're dosing off of that component. Here, for Bactrim, we always use a trimethoprim. Again, I don't know who said that that was going to be the standard, but that's the standard, right? However, if you were looking at something like amoxicillin clavulanic acid, what do you think we dose off of? the amoxicillin, right? Because that's the important part of the component there. Some of the more important, because that's what kills off the bacteria, right? In this case, they're both active. It's just trimethoprim ended up getting the preferential treatment, I guess, right? Very good gram-positive coverage. This does cover MRSA, and I should have said Clinda also covers MRSA, so if I wasn't clear about that. Clindamycin, Bactrim both typically cover MRSA. Now, again, you'll find that in a lot of cases, for like skin and soft tissue infections, if you're treating on the outpatient basis, Bactrim is really good for that for MRSA coverage. Clinda is really good for that, but you do see resistance that can develop over time. That's where you have to use something like Vanco as like a backup if they're going to be going inpatient. Okay, so just something to consider there. There's another one that doesn't cover Enterococcus, very similar to the cephalosporins as a class, to not do that. And we use it very frequently for a lot of gram-negative aerobes here. Oftentimes, you'll actually see Bactrim being used for prophylaxis for opportunistic infections for certain type of bugs. And again, if we have a nice, healthy immune system, like I'm sure most of you have, you don't get infections with things like Burkholderia cepacia. You don't get things like Stenotrophomonas multifida. People have poor immune systems, like those who have cancer, who are on chemotherapy, those who have AIDS. They typically have a poor immune system. They get these infections. These are opportunistic. And so you'll see Bactrim used on them pretty frequently. So if you ever see someone who's on Bactrim, say Monday, Wednesday, Friday, with no stop date on it, that's usually what it's on there for. It's for prophylaxis for an infection rather than the actual treatment. Okay? Because again, usually when you write for antibiotics, you want to write for a definitive duration because you don't want them to be on it forever, right? These are one of those exceptions where you may see that occasionally. Again, you use this a lot for PCP, which is pneumocystis carinii pneumonia, which again comes as an opportunistic infection in those patients I mentioned that have poor immune systems. This is used very frequently for a lot of urinary tract infectious diseases. It will have good coverage against like E. coli, Proteus, things like that. Occasionally we use it for respiratory tract infections. That's pretty rare for the most part, I would say. You see a lot more macrolide use and a lot more, penicillin use. And then the other big place you'll see a lot of Bactrim being used, if you ever go like do medical mission trips or travel or anything like that, can be used for a lot of traveler's diarrhea and other infectious diarrheas like that. Okay, as far as adverse effects go, this is another big one to watch out for as far as like sensitivity goes, as it manifests as the skin manifestations, namely Stevens-Johnson syndrome, toxic epidermal necrolysis. Just be aware that's going to be a potential risk there. And again, because this inhibits the utilization of folic acid, very similar to how it works on the bacteria, it does have some cross reactivity with our cells, and this is why you're going to see those really fast dividing cells like the white blood cells can be hit, right? Or other blood cells like thrombocytopenia can occur here, granulocytosis, because again, those rapidly dividing cells can also take a hit from us as well. So we'd like to have 100% selectivity, but it's not always the case. Okay. Now this does inhibit the CYP enzyme 2C9. This is more important than I would say like a 1A2 interaction, but not quite as important as 3A4. But when it does occur, you want to be really careful with it. Namely, warfarin is one of the big ones that this will interact with. You increase your levels of warfarin, that's going to increase the anticoagulant effect. All of a sudden, a patient can bleed out. Okay, so be very careful with that. This can also lead to other things like decreased renal clearance of methotrexate, which is another immunosuppressant that can be a problem. Yeah, those are the big things, right? So anything metabolized by CYP2C9, the levels are going to go up when you have Bactrim on board, right? So I could ask it as a question. I could say you have a patient who's on phenytoin, which is a CYP2C9 substrate. Which of these drugs can interact with that to increase the levels, right? And so I may put like levofloxacin, which is a 1A2 inhibitor. I may put, erythromycin, which is a 3A4 inhibitor, and then I'll put, Bactrim as a 2C9 inhibitor, right? Maybe penicillin or something as a kind of a red herring there, right? So again, your key is to remember, okay, yes, I remember Bactrim inhibits CYP2C9. That's what I'm going to be concerned with, okay? I'm not going to have you know that phenytoin is a CYP2C9 substrate. I will tell you though in the question for this test. Something similar. Hopefully I did not write that exact example. I just gave it away. Anyway. Next up we have Flagyl or metronidazole. This has very good coverage against anaerobes only, right? That's kind of its big niche use. It also will get parasites, okay? So very frequently this is used in combination with gram-negative covering sort of drugs like, say, third-generation cephalosporin for intra-abdominal infections. We use that very frequently for patients who are coming in for appendicitis. We'll cover them with like Rocephin, ceftriaxone, which will get a lot of gram-negatives, and then we'll also cover with metronidazole, which gets to anaerobes. So good for intra-abdominal infections there. You'll also see this used very frequently for vaginal infections and things like that, pretty frequently. So the one thing to note with this one is that the one kind of really unique side effect, and the one thing you always educate your patients on, and again, I don't know how frequently this really ever comes up. I imagine if I have an infection, I don't really feel like drinking very much. I don't know, but some patients may do that. So there's what we call a disulfiram reaction, okay? Basically, when you have alcohol, it goes through a two-step metabolism process, one of the processes it goes through, where it'll break down alcohol, ethanol, into this product called acetaldehyde, okay? So an enzyme called alcohol dehydrogenase, pretty easy. So acetaldehyde itself is very irritating to the body. It causes a lot of vasodilation, causes flushing, causes sweating, causes nausea, a lot of vomiting associated with that. Now, normally, our bodies can process that acetaldehyde through another enzyme called acetaldehyde dehydrogenase. Again, very simple naming convention there. That then breaks it down, and eventually it'll turn into CO2 and water, and you don't have to worry about it. This drug will actually inhibit the conversion from the acetaldehyde into the next step by inhibiting that acetaldehyde dehydrogenase. What that means is if you have someone who's drinking ethanol along with metronidazole, you're going to increase levels of that acetaldehyde. They're going to get flushed. They're going to get very sweaty. They're going to be very nauseous and probably vomit. The reason why we have this drug, we call it a disulfiram reaction, is because the original drug that did that was disulfiram, and the brand name for it was Antabuse. We would actually give it for patients who were alcohol dependent. We give it to them so that way if they ever fell off the wagon and drank, they would get really sick. Well, how good do you think compliance was with that? Pretty poor, right? The guy's like, I'm just not going to take it, right? And I can drink whatever I want. So not a great drug from that standpoint, but this does have that same interaction there, okay? This is also the same thing you may see in certain patients of Asian descent. If they ever have, they call it the Asian flush sometimes when they drink, that is due to they have a genetic predisposition to have less acetaldehyde dehydrogenase. So for instance, one of my medical directors in the Poison Center, his name is Dr. Kunisaki. He was of Japanese descent, and he would not drink. He just knew that if he had any drop of alcohol, he would end up having this horrible flushing, get super sick, and just said, I'm just never going to do it, right? But that's the same reaction, right? So again, whether you're inhibiting that enzyme or they have a lack of the enzyme, the same thing occurs there, right? Due to that acetaldehyde building up, right? Anywho, all right, so those are the big things to note with Flagyl. Typically, one thing I think about as far as anaerobic coverage goes between between Clindamycin, which has had a good anaerobic coverage in gram-positives, versus Flagyl. One thing I heard that helps me remember kind of the uses of those, think below the diaphragm, think Flagyl, think above the diaphragm, Clindamycin. Right, so if you had something like an aspiration pneumonia where you had like anaerobes getting into the lungs, Clindamycin is a good coverage for that. GI stuff, typically you're going to be thinking more metronidazole. Okay, so below the diaphragm, metronidazole. Above the diaphragm, and again, like vaginal stuff, things like that, metronidazole is good. Above the diaphragm, think clindamycin. Okay, it's not always going to hold true, but again, this is something that helps me remember it. All right, so that's the end of the antibiotics. Any questions on that? All right, so let's see what we can get through as far as derm goes. And again, I updated this, so if you need to update a new or download a new copy, please do so. Right, so the skin, it's a pretty big organ, right? What's the skin good for? Preventing infection, keeps water in, keeps us, we can cool ourselves or warm ourselves up, all kinds of different things the skin's going to help us with. And actually, you're going to find that there's a lot of variability in skin depending on where you're looking at. So, for instance, how's the skin on, say, the soles of your feet compared to, say, your armpit? It's a lot thicker on the soles of your feet than it would be on the armpit, right? So again, noting these differences can be important when you're applying drugs to the skin, right? And again, when we talk about, looking at drugs applied to the skin, we're going to find that a lot of them are going to be used very locally to treat a local sort of reaction. Some of these can actually be used for systemic purposes. So for instance, if you ever see, I don't know if anyone's ever gone on a cruise before and they get really seasick, there's a drug called transdermscope or scopolamine. You just put it right behind their ear and it helps with seasickness. Well, that's not working just right there. It's not like it's any more effective for treating nausea and vomiting if I put it here versus on my stomach. But what you find is that drug can be absorbed systemically through the skin. Okay. There's pain medication patches like a Duragesic or fentanyl patch you can see with that. Those are going to be for more systemic purposes. Today we're going to mainly focus on things that are going to be working more locally, okay? Or we're going to talk about drugs that are going to be taken systemically to treat skin manifestations of things like acne and whatnot, okay? Just know that some of the things that can increase the absorption of drugs through the skin, which again, this is maybe a bad thing in certain cases if you're worried about certain drugs getting too much absorbed, right? That can lead to toxicity, so you got to be careful with that. But things we're going to be looking at things like concentration gradient, right? What does that mean? Higher concentration outside versus inside, right? So you got the higher the concentration of the drug, the more likely it's going to push through just based on passive diffusion through the skin there, right? The thickness of the skin is going to make a big difference, right? So if I apply drug and I apply it to the axilla versus if I apply it to the soles of the feet, which one has better absorption, do you think? Exactly, right? So again, thin skin, that's why kids get to be a problem with that, right? So kids typically have underdeveloped stratum corneum. They absorb drugs better through the skin. I don't know if I ever mentioned that example, or the babies were getting put on that lotion and then they were testing positive for THC. Moms are negative. They're like, what's going on here? That's because they could absorb that stuff, right? So again, a lot of that is going to make a big difference here, because again, you want things that, if you want them to act locally, you want them to act locally and not get systemic. And so things as far as like what type of dosage form you're going to use, whether I choose an ointment or a gel or a tincture or anything like that, or the concentration, all these are going to be playing a role in these decisions here, which we're going to kind of go over at this point, right? Okay. So looking at this, again, looking at the considerations for our dermatologic vehicles, which just means that what are we putting the drugs into to get them onto the patient's skin, basically, right? That's all the vehicle is. Looking at things like drug solubility, so oftentimes we may need to put things in a more alcohol base or a higher ethanol concentration base to get it solubilized. It just depends on the drug itself. Other things to note as well is how well can the actual vehicle sort of hydrate the stratum corneum, right? And again, one of the big rules with, have you guys started derm yet in your ClinMed course? And what's kind of the golden rule as far as like, wound care or, just things in skin in general?
If it's wet, make it dry.
If it's wet, make it dry. If it's dry, make it wet. Yeah, it's similar. So you're going to find that is going to hold true here as well. And so you're going to find that, things like hydrating substances are going to make it more easy for drugs to be absorbed in those cases there. And again, stability is another big thing, right? Because anytime you put a drug into a solution, the stability is going to go down, right? When I say stability, what does that mean?
Like it's more likely to break down and come apart.
Exactly. So low stability means it's going to break apart and not be usable anymore, right? And again, you also worry about anytime you have a liquid preparation, you also worry about things like bacteria starting to form. So sterility can also be a concern as well. That's why we have things like preservatives and things like that will get put into these products as well, right? Because again, if it can freeze dry something, if I can keep it very, very dry, and oftentimes you'll find a lot of drugs come in just like a little powder at the bottom, that's very stable. It'll be stable for many, many years versus if I put it into a liquid, that's when it becomes less stable, right? Anyway, so general rules, if it's wet and you're having a lot of acute inflammation, maybe some edema there, let's dry it off, right? So any kind of oozing, crusting, things like that, we can try to dry it out. And I'll talk about the different vehicles we'll use in order to do that. If it's dry, especially if you see like a lot of chronic inflammation, that's where we're going to be using something to try to wet it, right? We're going to use more hydrating sort of vehicles in order to try to get that skin kind of back to normal, essentially. You're going to find that when you're dealing with very hairy areas, depending on who your patient happens to be, you're going to find that certain things may be more convenient or less convenient to use, right? So I don't know if anyone here has ever tried to apply like a really thick ointment or something to a hairy area of skin. It's not fun because, again, you're just making a big mess and it gets on your clothes, and not that I've done it, but it's just not fun. However, things that tend to dry really quick. So if I had more like an alcohol-based sort of tincture or a lotion or something that dries up pretty quick, tends to be a little bit more pleasurable, right? And so typically what you're going to find as far as compliance goes with these things is a lot of people don't like to put on really thick ointments or really greasy feeling. Compliance goes down for that versus if I had like a spray, I could just spray it on, then you're good to go, right? The compliance is better for that sort of thing. May not be appropriate depending on the patient and the condition, but just depends. So looking at delivery systems, we have things like wet dressings that can help with some evaporative cooling, can cause some vasoconstriction. That can be very useful. In some cases, we'll have things like powders, which can be very drying. And so a lot of times if we have like, especially if you have things like ostomies and things like that, or G tubes, we'll have infection that may develop around the site. You can apply powders there to help kind of dry it out and prevent some of that bacteria from growing and absorb a lot of that moisture, which is good. Lotions tend to be usually a suspension or a solution itself, and again, don't get too bogged down whether it's suspension or a solution, but typically it'll be in a more watery vehicle, right? So again, when you think about a lotion compared to an ointment, how would you compare the consistency of them? Yeah, lotion's like thinner, you don't really get that nice greasy feel like you would see with like an ointment or something, right? So that's because it's in a water base, right? The water content's much higher, and a lotion that's going to be in something like an ointment, okay? And again, when I'm talking about solutions, just something that does dissolve into one of those vehicles there. As far as gels go, gels typically have an alcohol base. So because of that, alcohol tends to evaporate very quickly. Those tend to be pretty drying, right? So just like if you ever spray isopropyl alcohol into a table or something like that, it evaporates very quickly and dries very quickly. Same thing goes for any kind of alcohol-based vehicle or product, and gels include that. Now, when I say an emulsion, what's an emulsion? Yeah, it's kind of like mayonnaise. Mayonnaise is an emulsion. Did you know that? So you're putting, oil mixed with something that really doesn't like to mix with, usually water-based. Something like vinegar and oil, something like that. But basically, you can have two types of emulsions. One can be oil and water, and one can be water and oil. Basically, oil and water means that you have a higher water content, so again, it's going to be less greasy than you would have something like a water and oil sort of emulsion. Oftentimes, we have to use emulsions because of either stability or the solubility of the drug is pretty low, and so we have to do that in order to get it into a proper solution where we can actually apply it for the patient there. But again, the higher the water content, typically the less greasy it's going to feel, the less viscosity it's going to have to it, and we'll talk about occlusion here in just a few minutes, what that can mean for us. Creams tend to be the most common vehicles that you're going to find with dermatologic products. Most of them tend to be oil and water emulsion. So again, the water content's a little bit higher there. Again, when I say occlusive, what do you think that means? It covers it and it kind of stays there, right? So you're going to find that things like, lotions, creams may not be the most occlusive. If I have like something like, thick ointment or something like Vaseline, if I slap Vaseline on something, that thing's staying there all day, right? That's very occlusive. And again, what do you think that does for drug absorption? What do you think has better drug absorption? Something's more occlusive, something's going to stay there and stay on the skin for a longer period of time. So again, if you need something to be there for a while, that's where we're going to use something that's going to be more viscous, more thick, more of that sort of oil-based, oil-based basically, right? Anyway. As I mentioned, ointments tend to be more water and oil emulsions. Again, they can help to relieve dryness. They tend to be more hydrating, but again, they are not good for hairy areas. They're not good for, areas like that where it's going to be kind of making kind of a big mess, but it's good for like damaged skin because it helps to provide that kind of occlusion there. That's why you see a lot of antibiotic ointments. They come as ointments because they will stick on the wound and they will just stay there and help to provide that nice kind of local antibiotic effect versus just washing away very quickly, right? So you see something like Neosporin. It's a triple antibiotic ointment. That's why we like that. It's because it is more occlusive than something like a lotion would be, right? Aerosols, typically less efficient, more expensive just due to the convenience factor, but people do like it because again it provides a nice quick onset, but doesn't stick around for a long period of time, right? And usually a lot less, you don't find as many, that same kind of occlusivity, that same kind of greasiness as you would see with a lot of other products, right? So looking at kind of the list here, you can see that for things that are much more kind of moist and wet, you want to use something that's going to be more drying. So things that are alcohol based, things like that, lotions, gels, things that are going to be more water based tend to be better at drying things out. Going down, looking at things that are going to be more ointment based or more of a sort of oil base, you're going to find these tend to be better for dry skin, things like that, where you're going to be least drying. Okay, because again, if I can apply something very thick over the skin, that also prevents that water from evaporating out of the skin as well, which is why it can help to hydrate it, right? Anyway, this is a nice table. We can kind of look at it to see kind of the differences between the different products here. It's not important to memorize every single fact off of here. Again, I've kind of gone over the broad strokes already as far as the differences between these, but it can be useful when you're looking at it to see like, okay, well, what's kind of the advantage here between, say, for instance, a cream versus, say, an ointment, right? Creams spread pretty easily, no greasy feel, versus using something like an ointment, it spreads pretty easily, but it's going to leave that big greasy film on there that patients may not feel too comfortable with, right? So again, just depends on the product, on the patient, depends on lots of things on which vehicle you're actually going to use here, right? Okay. So looking at it, one of the most common things you're going to be prescribing or recommending is going to be topical corticosteroid agents. So what do we use topical corticosteroids for, do you think? Inflammation, yeah. So if you have things like, contact dermatitis, atopic dermatitis, things like that, typically topical corticosteroids are going to be used pretty frequently. Now, are these prescription only? Do you know? No, they're very ubiquitous, right? You can find hydrocortisone cream anywhere. You can find drugs, right? So going to the CVS, Walgreens, you can find this stuff. But again, that's important because your patients are using it without a prescription, without any kind of medical advice. They could be using it for a long time. They may not be telling you about it. So it's important to ask these kind of questions like, what are you using that you can get without a prescription? Oftentimes it will kind of clue you into some of these drugs that are over the counter that they're using, right? And again, there's going to be some important things to note as far as where you should be applying these, where you should not be applying these, as we're going to see here, right? Now, again, you may find that if you have an actual infection occurring, that applying a corticosteroid to it is not going to be ideal. Why do you think that is? Well, inhibit healing, so you can inhibit wound healing potentially. What does it do for that infection, though?
Growth of bacteria. If it's a fungus, it can
Yeah, so basically you're inhibiting the host immune system, right, locally. So if you inhibit that, that can lead to things like fungal infections starting to kind of run more rampant, essentially. So you have to be careful with that. And again, be aware that typically when you're applying it topically, you're not going to see a lot of systemic effects. But the more occlusive of a product you're going to use, the higher the concentration, the more potent of a steroid. We'll talk about that in a second, the different potencies. And the more thin areas you're going to apply it, the more likely you are to see absorption, and you're going to see the systemic effects. Okay. Now we haven't talked a lot about corticosteroids systemically as of yet, but things you're going to be looking for include like decreased ability to fight off infection. You're going to find that hyperglycemia occurs here. Some people get really kind of altered mental status when they have steroids on board. So again, if we're treating a topical issue, we don't want that to occur. We don't want systemic side effects. Otherwise, I should just give them a prednisone tablet or something, right? Anyway, other things you're going to see with this is that some of the side effects you're going to find, and again, this is all going to be dependent on the frequency, the duration. The longer you're using it, the higher the concentration product, the more likely you are to see some of these changes. If it's something like, hey, a little bit of dermatitis, apply some hydrocortisone cream for a weekend, not going to find these to be a big issue here, right? Again, things like dermal atrophy, because again, you're inhibiting the ability for the skin to grow in those cases with the corticosteroid. See some fine hair growth, some changes in kind of the quality of the hair, bruising, and then you also see some striae that can develop over time. And again, these are going to be for more chronic, long-term sort of use, okay? One of the things you'll note, and we'll talk about the different potency of steroids, typically you want to shoot for using low to medium strength agents. We'll talk about some of the higher potency ones and where they're going to be more useful, but be very careful whenever using really high potency steroids. If you go to work in derm, you'll get very comfortable with using them and when to use them. But if you're not sure, if you only kind of dabble in dermatology, as I do, just stick to low to medium strength sort of products here, okay? They'll keep you out of trouble. So some examples, you're going to find that there's a wide variety of different strengths, of different salts that are out there, and you'll find that depending on the salt, you can actually find that some of them will actually bump up to different categories. So I can have, like, say, a low potency steroid that if I just change the salt form of it, I will actually bump it up to a medium potency steroid, meaning it will have more likely to see those systemic effects. It'll be stronger acting. So if you had a larger amount of inflammation, it'll be better at kind of treating that and dealing with that inflammation. So just be aware of that. And again, note there's all sorts of different dosage forms that are out there, right? So again, there's hydrocortisone ointments, there's creams, there's lotions. Hydrocortisone is probably the most common one you're going to run into, and the 1% is usually the most common one you'll see as well.
What do you mean by changing this salt?
So I'll show you that in just a second. But for instance, if you're looking at like a hydrocortisone, like a Valerate versus, I'm trying to think of another example. I'll show you one in just a second here. But again, which dosage form you pick is going to be dependent on what you're seeing there. So if the skin really dried out, use something that's going to be more occlusive. Use something like an ointment. If it's really kind of more, kind of weepy and having, very wet, use something that's more dry. Use something like an aerosol potentially, or something like a lotion, right? I think it's going to be better for that. Let me see if I can find an example of that. I think I have it on another slide. But again, you're going to find that typically with topical products, you have to apply them pretty frequently. So twice a day at a minimum, more often than not, 3 times, 4 times a day. So compliance is always going to be an issue with these. Because again, as soon as they're off of the skin, when they get washed away or just do normal daily activities, you're going to find they're going to not work anymore, right? And typically what you're going to find, especially for patients that have chronic inflammation, chronic dermatitis, and things like that, you're going to find that typically for routine daily use, we're going to be using more mild forms, more weaker forms, and that if they have a flare-up, something comes up, they have an exacerbation, that's where we're going to kind of bump them up to something stronger. And again, if we can get them back to the weakest dose possible, that's going to be better for them, right, from a side effect standpoint. So again, for flare-ups, bump it up and then go back down whenever you can once that flare-up's under control. Okay, that's going to be a general rule of thumb when dealing with steroids for just about anything, whether it's be rheumatoid arthritis or dermatitis, anything like that. Typically, you're going to try to bump it down to the lowest dose possible steroid as you can. Okay. Now again, as I mentioned, the absorption varies greatly depending on where you're going to be applying it to. So for instance, the face and the cheeks, typically you're going to be more likely to absorb because it's thinner skin. And unless you get slapped a lot maybe. Sometimes I do, but I say really dumb things sometimes, but you can find that absorption is going to be a lot better in the thin areas of skin. You want to use a lower potency agent, right? Things like the forearm tends to be thicker skin. You can use something like a more medium or high potency product if needed, okay? And again, I'll show you some examples of different potency products here, but just be aware that thinner skin, you want to use a smaller concentration. You want to use a weaker agent than in the thicker areas of skin. Okay, as mentioned, the ointments tend to be more occlusive, so they're going to be sticking around for longer. They typically have more potent effect than something like a cream is going to be, right? But remember the drying or the hydrating sort of effects of the various products there. Okay, and again, use caution anytime you're applying topical steroids to very, very thin areas of skin, as I mentioned. So the face is a big one, the scrotum, the vulva, skin folds, anything like that. Why do you think skin folds typically tend to be more likely to see drug absorption?
For a longer time.
Yeah, so they're going to be sticking together for a longer period of time. So that drug may, if it was on your forearm, it would get wiped away just with normal, walking around doing things. But with skin folds, you're going to find that they'll stick together and the drug will stick around for longer. That's actually a big thing from a tox standpoint. We think about if you're dealing with, like, say, a mass casualty event or there's like a chemical spill or something and you're decontaminating patients, you have to really make sure you get the skin folds, because if they had some kind of irritant that got caught between those skin folds and they're just sitting there, it's just going to cause more and more damage over time. So think about skin folds as being a very occlusive sort of area. You're going to see more absorption there. Okay. All right, so some examples. So looking at some of these different agents. So hydrocortisone, as I mentioned, is going to be one of the most common ones. Hydrocortisone acetate is the most common salt form. Again, I'm not going to quiz you on which salt versus which is going to cause these issues. Again, I'm not a derm expert by any means, but know the differences between, why would I use a low potency agent, when I might use one versus a higher potency agent, right? But hydrocortisone typically pretty on the low side of things. But again, looking at the salt form is important here. So acetate's the most common one you find over the counter. If you switch it over to a valerate, it's 0.2%. So even though it's 0.2 versus 1%, this is actually going to be more potent and considered medium potency. Okay, so just looking at the numbers, you'd be like, well, that looks less potent because the concentration is lower, right? It's 0.2% versus 1. However, it is more potent because that salt form gets absorbed better, has better activities at being an anti-inflammatory, right? Now the big one's desonide that gets used pretty frequently. And again, lower potency agents are better for the face, skin folds, etc. Moving up to more medium potency ones, these are going to be better for, things like psoriasis, more kind of intense inflammation or these kind of flare-ups. Triamcinolone's a big one. So Kenalog, if you ever see Kenalog, that's a big one. They'll be used for things like eczema, psoriasis, etc. As far as high potency goes, we have fluocinolone, which again, 0.05%. So again, it's a very low concentration versus that hydrocortisone 1% we were looking at, right? It's a 20th of the concentration, basically. Less than that, right? It's only 5%, I should say, of that concentration there. You're going to find that, it's still very, very potent. It has a very good activity. You want to avoid using it in the very thin areas of skin there, right? And we have things like ultra high potency agents. Clobetasol is going to be one of the the highest potency ones you're going to run into. Again, I would not mess with these unless you are working in derm. You're an expert at dealing with these sorts of steroids. Stick with your lower ones. As TLC once said, don't go chasing waterfalls. Don't go chasing those really ultra high potency agents unless you know what you're doing, right? Stick to the hydrocortisones and triamcinolones you're used to, right?
Do we have to taper these ones, or?
Typically, no, it'll be less of an issue with that. Typically, with some of these topical products, you find that the skin can act as a sort of reservoir, and so that they will kind of taper themselves off as you go along. You may find, and again, talking with someone who does derm every single day, dealing with these like really, bad inflammation cases, like they may have a different story to say, but you don't think about the same tapering as you would see for like a topical or oral steroid, right? At least that I'm aware of. Anyway. Other things you could use potentially. So we call these topical immunomodulators, or TIMs. These work sort of like steroids, but you're going to find they have a little bit more specific activity, right? Because remember, steroids are working at the site of the nucleus to change transcription factors, to change the production of inflammatory cytokines. These are going to work more specifically on things like T cells. They can decrease things like mast cell degranulation, keratinocytes, all those sorts of things. So a little bit more specific, but you're going to find that, depending on the agent, may not be as potent as some of those steroids, but may limit some of the side effects. They'll have their own side effects, as we'll see here in just a second. But the two we have are going to be pimecrolimus and then tacrolimus. And in fact, these are tacrolimus is actually a drug you're going to see if you're used to dealing with transplant patients. You'll see that used pretty frequently. Or patients with like autoimmune conditions where you're trying to tamp down the host immune system. You'll see these being used systemically. So I see tacrolimus used a lot in some of our patients, Nemours. But these are the topical forms, right? So we have Elidel and then we have Protopic here. And again, they have a better side effect profile than the steroids, as far from like a skin thinning sort of standpoint. Any kind of discoloration, acne is another thing we'll see. The topical steroids can also worsen, just due to the fact that where does acne come from? Right, so you have a lot of sebum production, right, but also there's bacteria that grow there, right? So again, if you have topical steroids on board, you can't fight off infection as well. Acne can be a side effect from that. But again, you're going to see less of that than with this, right? So you're going to find that tacrolimus is pretty similar to other medium potency agents. Do you have a question? Yeah, we're going to talk about that. I don't know where I talk about it. I think I have it in a slide. Anyway, right, so tacrolimus kind of works very similar to a medium potency agent. You're going to find pimecrolimus is more of a kind of a low potency sort of steroid if you had to compare it as far as that activity goes. Now, the big things to note with these is that you have to be very careful with sun exposure. Big deal in Florida, right? So you have to make sure they're wearing very high SPF sunscreen to make sure, because they're going to be very photosensitive in those areas where the drug is being applied to, right? So they're much more likely to see sunburns and things like that. So you have to be careful. And of course, we're going to find that anytime you're kind of messing with the immune system, as some of these drugs are going to do, there are risks for things like secondary cancers that can occur. But again, this is going to be less likely with the topical form than you would see with, say, a systemically administered form. So just something to keep in mind there. Let's see. And again, if you needed to have a patient who could not tolerate steroids, maybe either due to systemic absorption, maybe due to other issues, these are going to be good alternatives to those, right? Probably not first line in those cases, but if you could not use a steroid, these would be good alternatives to those. Okay. And again, when you're looking at things like contact dermatitis, what are some of the common things that will cause this?
Metals.
Yeah, so when talking about more like contact, so again, we're you're gonna find that, yeah, poison ivy, but more often than not, you're gonna run across things like soaps, metals potentially. Yeah, so again, think of the common things you're gonna run into. Obviously, if the patient's been hiking recently, I would think of something like that. But again, oftentimes whenever you have a patient with a derm complaint, you always ask, hey, have you had any new soaps, detergents, anything like that they've been exposed to? Because that's probably the more common things they're gonna run into. And again, we're gonna find that things like steroids can be very useful for helping to treat these. Now, again, if you just have a really localized sort of involvement here, limited area you're trying to cover here, this is where things like topical hydrocortisone can be very good for treating those. And again, depending on how bad the inflammation is, you may need to bump it up. But for the most part, OTC stuff is going to be able to cover that, right? And again, depending on how the skin's looking, you're going to choose either a drying agent or more hydrating sort of agent, depending on the case there. If they have really severe, especially more widespread sort of inflammation, this is where things like systemic therapy can be very useful. So when we talk about things like prednisone, dexamethasone, we'll talk more about that like in the ENT section a little bit later on. But systemic steroids can be better for more kind of body-wide sort of inflammation. Okay, those are the ones you have to think about tapering if they're on it for more than a week, and we'll kind of reiterate that point later on. But those are things you can use because they are working more systemically. They're going to be able to work kind of all over in those cases. All right, any questions so far? Anything we covered? All right, so moving on. Next up, just real briefly, we'll talk about impetigo. Again, when you think about skin infections, what kind of bugs are you thinking about? Staph, gram-positive in general. Strep is another big one, like Staph epi, Staph aureus. These are big things you're going to be seeing pretty frequently here. Now, again, for impetigo, depending on how diffuse the disease is, sometimes you can get away with just topical products. Some cases we can use more systemic products if it's more diffuse here, right? So things like dicloxacillin, right? Dicloxacillin fell into what category? Antistaphylococcal. So it covers what kind of form of staph? It'll get MSSA, right? So if you're really worried about MRSA, it will not cover that, right? Similarly, something like cephalexin, right? Remember, cephalexin fell into what category? Cephalosporins, more specifically.
Generation 1.
Yeah, first generation cephalosporins. That also covers MSSA, but again, it's not going to get your MRSA, right? So again, the question is, like, if you start treating these patients, if you treat them, 7 days worth of dicloxacillin and they're still having the same issues, you obviously know it's not going to be MSSA. It's probably more likely to be something like MRSA in those cases, right? So it's something to think about. Yes.
So in that case, if you have impetigo, do you automatically assume this is MRSA until further?
Kind of depends on where you work. It depends on what the kind of the common strains are in your area. You'll find that after a while, you've been treating so many patients, you're like, man, this stuff just doesn't work for these patients. I have to go to Clinda every single time, right? Because Clinda, being a strong gram-positive coverage sort of antibiotic, does cover MRSA, right? So again, if you were concerned about either the community rates of MRSA being widespread in your community wherever you happen to work, which again could be different if you work in Denver, Colorado versus if you work in Hawaii versus here in Orlando.
Or somewhere like underserved where there's extra
Right. So again, if you're thinking about something like that, maybe an underserved population, or depending which country you're even working in, for that matter, you may find the MRSA rates may be higher or lower, and so that would lead you to say, well, maybe we're just going to go ahead and be more conservative and use a bigger gun like Clinda for treating that. However, what's the problem with using something like Clinda versus something? Right. You worry about resistance. You worry about C. diff. Things like that can develop.
How come, you couldn't use tetracycline?
You could potentially, right? However, you're going to find that tetracyclines, due to some of the issues, like dicloxide, like penicillin's like easy, right? You don't have to worry about like dietary interactions. You don't have to worry about that, the teeth and bone staining thing, like young kids and pregnant patients, so sometimes you can get away with something much more narrow spectrum. Remember, the tetracyclines tend to be a lot wider in spectrum, right? So again, that's something we'd like to use narrow spectrum whenever possible. So if we have impetigo, we're thinking probably MSSA or something like streptococci or something like that. Let's use narrow spectrum when we can, right? So that's another concern to think about. Okay. Now, if you have topical products we can use, there's one called Mupirocin or Bactrim. This is used very frequently in the hospital. If you do a nasal swab on a patient, they come back positive for MRSA, oftentimes we'll get Bactrim to try to eliminate that nasal carriage of MRSA. Because again, if it's in the nares, then it can spread around to other people potentially, and you can have that spread on a unit. Don't want that. This one actually works by inhibiting bacterial tRNA utilization, so you can't actually produce new protein. So instead of the ribosomes, actually working on the tRNA instead. That's used very frequently. And then we have this rotapamulin or our Altabax. This is actually another protein synthesis inhibitor. And again, the nice thing about using these for topical purposes is, again, you limit the systemic side effects you run into. Now, again, very similar. We're going to talk about antiepileptics one day. You'll see that any antiepileptic can cause seizures. Any antiarrhythmic drug can cause arrhythmias. Any topical product can also cause what? Dermatitis, right? So dermatitis is going to be right because people can react to all sorts of things, right? So again, especially some people are more likely to react to things than others. But any topical product could potentially cause dermatitis. So just like antibiotics often cause nausea, vomiting, diarrhea, this can cause dermatitis potentially. Any of these products can. So just one caveat to consider there. And so those are big things. Again, whenever you have an infectious cause for one of these disease states, you do not want to use steroids for those because, again, you're inhibiting the host immune system from fighting that off. Yes, sir. Sometimes you can use it around the nose and for nasal carriage there. Yeah. We'll kind of get it around the rims there, I think. I guess I've never actually seen it applied to a patient. They order it and I give it to them. Yeah. So again, because again, the nasal swab's getting right there in the nares, so you want to apply it to the same area there. All right. Okay, moving on to acne. This is going to be kind of the bulk of the topics here we're going to cover because it is something that affects a lot of people. Some of you may have experienced at some point in your life. It causes a lot of psychological distress for a lot of patients too. And we have a lot of drugs that can help to treat this. Okay. So again, acne is going to be produced by several different factors here. One of the big things is going to be this increased sebum production, which again is just kind of that fatty lubricant that gets secreted from these sebaceous glands. What you're going to find is those will typically kind of clog up the pores. You're going to find they have this abnormal keratinization that can occur over there, right? So that's how you can end up finding they kind of get plugged up. And when you plug up these pores, they're full of the sebum, what can then develop? Infection, right? So we're going to find they're going to have anaerobic bugs that start to grow in there, right? And so the big one is going to be this Propionibacterium acnes. This is going to be the big thing we're going to be treating, right? So when we treat this, we want things to have anaerobic coverage to kill that off. And that'll be borne out when we see the different treatment options we have for this, okay? And then again, once you have that infection, the body's going to want to react to that, and that's where you see a lot of the inflammation come from, right? So those are the 4 key components of acne that we're going to find that different drugs are going to be targeting different components of that, okay? And again, very similar to what we talked about treating a Pseudomonas infection using 2 drugs that have complementary mechanisms. Same thing here, right? We want to use different drugs that have complementary mechanisms when you have to use combos to make sure you get better activity against all these different components here. I'll show you what that looks like in a second. Of course, you're going to find that things like hormonal imbalances can obviously affect acne. This is where like some patients who have really bad acne, they get put on oral contraceptives, it can clear right up. Other patients, you put them on oral contraceptives, and it worsens it, right? So it just depends on the patients. You're going to find that it can depend on the hormone they're receiving, the amount of hormones they're receiving, all completely playing a role here. And again, when does acne normally rear its ugly face? No pun intended. Yeah, around puberty, right? When the hormones are going to be raging. Right? People with acne are pretty too, so I don't want to cast any aspersions there. Anywho, right, so looking at pathogenesis, we said you have this infection of this anaerobic bug that's going to be developing there. They're going to find that that's going to produce a lot of inflammation, right? And so you can find some acne is going to be more inflammatory than others. You're going to find that's going to be helping to dictate treatment too as well, when we see it a little bit later. But again, you have non-inflammatory, it's going to be kind of these open and closed or comedones there. And then the inflammatories, we're going to get more kind of these papulopustular sort of nodular lesions will develop, right? Here's some pictures kind of showing you what this will look like. The sebaceous gland will secrete the sebum there. It's going to get plugged up. This is where we're going to find that the bacteria are going to start to develop, and then inflammation is going to happen around here, right? And again, we can target 4 of these different mechanisms with different drugs in order to help eliminate this if we can. Okay, so acne therapy, there's no cure necessary, but we can treat and at least reduce the severity. Some patients will grow out of this. Some people are going to require more long-term therapy. It just depends on the patient there. And again, you're going to find it's going to be highly individualized. So I wish I could tell you that every single patient walks through the door with acne, you're going to treat them this way. Not the case necessarily, right? You're going to find it's going to be, and again, if you work in derm, you're going to know this way better than I ever will. But we are going to find that you have to individualize it, make it a little bit different depending on the patient you're dealing with, maybe different combinations, different strengths of drugs, etc. Right? And again, we're going to find that you need to at least give agents 1 to 2 months or so before you start to really see how effective it's going to be, right? So again, it's not going to be an overnight sort of thing where it's going to fix all their current lesions. It takes time for it to really kick in. So give it time and then reassess, and then you can make any changes to regimens, right? All right, so the goal here is try to get some early aggressive treatment on board, and then once we get them kind of under control, then bring it back down, right? So again, hit them hard aggressively initially, and then bring it back down so that way we can use lower concentrations of drugs, fewer drugs, and that's going to help us to limit a lot of the side effects we're going to see with these. Because again, these tend to have a lot of side effects associated with them, right? And again, if we can slow down the progression, if we can reduce the number of lesions, all these different things, these are going to be good. Of course, avoid that nice psychological suffering. Hopefully, they don't need an antidepressant to go along with their acne, but you never know, right? We'll talk about that later. Anyway, so again, the treatment we're going to be looking at trying to eliminate that microcomedone, right? So if we can eliminate that occlusion, get rid of that sebum, open things up, and maybe treat that bacteria, we're going to find that inflammation is going to go away as a result of that, right? So again, we're going to use pharmacologic and non-pharmacologic therapies, right? So it's important to note the non-drug stuff we can do is going to help us out, right? Because again, you're going to find there's always synergy between non-pharm and pharmacologic means, right? So we always want to emphasize that. Try to use multiple mechanisms, so complementary mechanisms to treat these, and then again, target those multiple steps, as we'll see here in a second. Now, for more mild to moderate sort of acne, again, if it's more localized, especially like just to the face or certain areas, you can get away with topical therapy. That's going to be good because topical therapy usually will limit the what? Systemic toxicity, right? For more moderate severe disease, treatment-resistant disease, more widespread disease, this is where you have to use systemic therapy, okay? Just be aware of that difference there because, again, the second you move to systemic therapy, systemic toxicity is going to be playing a role here. So, again, looking at the different drugs, you can go back to this slide here and make sure you can categorize them effectively. So things are going to help with this follicular keratinization, again, forming that actual comedone. We're going to find we have the retinoids, we have the azelaic acid, and then benzoyl peroxide. Again, benzoyl peroxide, where can you find that? Over the counter. That's the most ubiquitous. It's probably the ones your patients have already tried by the time they come in to see you, right? If they're coming to see you for this. So just be aware that's something that's going to be pretty widely available. As far as decreasing sebum production, this is where our retinoids are going to come into play, and then hormone manipulation can also be playing a role here, right? So things like oral contraceptives. Usually we're not going to be messing around with the androgens on the guy side so much, but certainly the female hormones, estrogen, progesterone, we can have be playing some role there. As far as suppressing the bacteria, often we're going to have things like antibiotics are playing a role here. Benzoyl peroxide is going to have good antibiotic sort of activity here, and then we'll also see our retinoids can help. And then as far as preventing the inflammatory response, antibiotics are going to be good for this along with the retinoids. Now we're going to go into those different groups and see how they're actually working. Okay, so as far as cleansing goes, obviously you want to clean your face. You should clean your face. You should clean your skin every day, right? However, there's always going to be sort of a caveat to that. Do you want to clean too often? What happens? Dry out the skin, irritate it. That can also lead to further inflammation, right? So again, with all things, there is a nice happy medium. You don't want to overdo it.
Isn't it also going to overproduce oil as a response?
You may see a little bit of that. Yeah, so for some patients it might be more pronounced than others, certainly. But yeah, so again, you don't want to overdo it. Twice a day is probably going to be sufficient for most patients, right? But again, you want to balance out the cleanliness versus the drying, irritation sort of effects here, okay? And again, soaps may not always be the best products to do for this. So again, once the soap is rinsed off, it's no longer there. It's no longer having any activity at that point, right? So that's one thing to consider. And also, you're going to find that in some cases, you may find that soaps may actually degrade other products. And so oftentimes the sequencing of these things can be important here as well, to where you may not want to apply a certain product to the face and then try to clean it with soap, because then when you're going to wash away that product potentially, and then it may actually degrade it, make it less effective. Again, twice a day is probably good, but again, some patients may be producing a lot more oils and things like that. They may need more frequent Now, again, topical therapy is only going to work to where it's actually applied to. And again, once you take it away, chances are it's going to be able to come back unless the patient is, change their physiology in some way to make it so that's not the case. But what you're going to find with topical products is that all of them are going to cause skin irritation. Okay, this may lead the patient to actually discontinue use. They may say, well, my symptoms are even worse than they were before I started treatment. What's the point of me doing this? So that's the one thing you have to counsel them about. Make sure they give them enough time to really make sure it's going to see efficacy before you switch them to something else. Generally start low dose and go up gradually. Okay, you don't want to hit them with the hardest things you have, because otherwise it's going to lead to a lot more irritation, a lot more likelihood they're going to discontinue use. Okay, and if you can, try to use non-alcoholic products. Why is that? Because alcohol is going to dry out the skin because it evaporates very quickly. Perfect. All right, so looking at these, again, this is another kind of graphic kind of showing you how we're going to be targeting the different pathophysiologic components here. Again, you can refer back to that. We're going to talk about these in more detail as we go forward. So benzoyl peroxide, as I mentioned, very frequently used. You're going to find actually gets converted over into benzoic acid in the stratum corneum. It'll be able to penetrate the stratum corneum, and it has good activity against that P. acnes that we mentioned before. Also has some kind of peeling and comedolatic effects, right? So it's going to help to deal with that keratinization and kind of open up those comedones and allow it to kind of breathe a little bit more, so to speak. Again, low concentrations, maybe 2.5% concentration is important for you to memorize, but just know, start low, once daily. You can try to increase that if needed, okay? Now, very frequently, you're going to find this is in combination with other products. So again, you can, instead of having to have a bunch of different topical products you're using, you can just find one combo product that can help with compliance as well. So that can be a good thing. Okay. Very frequently, you'll see it with combination antibiotics, so like erythromycin, clindamycin, etc. Right. Now, as far as adverse reactions go, be careful with their clothes, because it can cause some bleaching of that. Can also cause some bleaching of the hair as well. So depending on where you're applying it to, especially if it's right next to the hairline, you may see some bleaching. And again, irritating the skin there. Similar to benzoic acid is going to be azelaic acid or Azelx, and again, you're going to find that we don't know the full mechanism, but it's probably going to be pretty similar to benzoic acid. The other thing that this will do is also helps to convert or prevent the conversion of testosterone over to dihydrotestosterone. We'll cover this more later when we get into, like, men's health and androgens, but basically testosterone, while that is the predominant sexual hormone that males will produce, it does get converted over to DHT or dihydrotestosterone. That's actually more potent of an androgen, has more masculinizing effects than testosterone does. So if the patient's acne is going to be exacerbated by this DHT, giving this can actually help to prevent that conversion and will help to limit those sort of masculinizing effects, right? So it can help to limit some of those the kind of pro-androgen sort of effects there, right? Yes, ma'am.
Is that used anywhere else in medicine to kind of prevent that testosterone and DHT?
We do use drugs that help to prevent that conversion. So, for instance, we have something called a 5-alpha reductase inhibitor. Those are oftentimes used for like BPH, for benign prostatic hyperplasia. That's where we'll see those used often, but azelaic acid itself is not, as far as I know. Could be some cases, but I don't know of any. Anyway, again, start low. One time a day, can increase if you need to, but again, you want to make sure you kind of assess for efficacy, but the toxicity, the other big things you want to watch for, right? And again, irritation, dryness of the skin is the biggest thing you're going to see with these. Some of these will actually get better with time. That's why we try to educate them. Hey, it may seem like it's getting worse at first, but it will get better. You will get kind of used to it. The skin will recuperate and be able to deal with that better as therapy goes on. Now, moving into the topical retinoids, these are going to be, again, a totally different class. These are going to be working very differently. And the first one we have is retinoic acid. Okay, other name for this is going to be tretinoin, and this is actually the acid form of vitamin A. Okay, this is very important to note, is that anytime you're messing with things like fat-soluble vitamins, these can be things that are going to be affecting the fetus in a pregnant patient potentially, right? So be very careful with retinoids when dealing with pregnant patients. You're going to find that you typically want to avoid these at all costs. Now, I'll give you the example in just a few minutes here where that's especially important. But basically, we don't know the full mechanism, but we do know that it attacks different sort of pathophysiologic steps here. So it helps with the inflammation, helps with the P. acnes, helps with that keratinization we were seeing there. Okay, very frequently you're going to find this is a good first-line agent, especially if they've already failed things like benzoic acid. They've tried over the counter at home. They're coming in to see you. Oftentimes, a topical retinoid is going to be recommended. Retinoic acid may be one of the first ones you're going to use for a lot of them. Okay. Also, this can be good for things like wrinkles. I remember when I went on a cruise with my wife, we went to Nassau for a day, and actually in the pharmacies there, retinoic acid is actually available over the counter. She was so excited because it wasn't here. I said, "You don't even have any wrinkles." She's like, "I know, but I want to prevent them in the first place." So. Okay. And then dyspigmentation as well. This can also help with changing some of that pigmentation you see there. Anyway, So looking at the adverse effects, again, a lot of skin irritation. You see erythema, desquamation, so you can actually have the skin starting to break down, burning, stinging. But again, this is going to get better with time. And also we'll oftentimes recommend that you use emollients. Or again, these are things that are going to help to hydrate the skin and help with that irritation there. Okay, photosensitivity is another big thing, right? So you're going to make sure they use a lot of high SPF sunscreen in order to make sure that they're going to be trying to prevent that photosensitivity from getting really bad sunburns with that. And again, avoid during pregnancy. You don't want to mess with fat soluble vitamins in developing fetuses. Okay, just like we were talking about warfarin, how that affects vitamin K. That's terribly teratogenic to a developing fetus. This one affects vitamin A. And what are the other two fat soluble vitamins? A, D, E, and K. So ADEC are going to be your 4 fat soluble vitamins. So again, don't mess with those in developing fetuses. Now, we also again, tretinoin is going to be photolabile. So this is actually when you actually want to apply at nighttime because the sunlight can actually break it down. So this would be a thing where after they've cleaned their face for the night, they can apply this to the skin at nighttime. And that way it'll be effective throughout the night. They can wake up, wash their skin again, and then it'll be gone basically. The other big thing to note though is that benzoyl peroxide will inactivate tretinoin. So you cannot use these at the same time together because otherwise tretinoin is not going to be very effective. You'll see we get around this in a couple of different ways in just a second here. Up next, we have adapalene or differin. This is actually one that is stable in sunlight, so this probably gets used a little bit more frequently. It's also stable with benzoic acid. Tends to be a little less irritating than you would find with just tretinoin. Tazarotene is another one. This is actually even further generation up. This actually gets used for psoriasis in some cases because it can help with some of that inflammation. So sometimes you'll see these retinoids being used other than just for acne, but sometimes for these inflammatory conditions as well. Okay, so those are the main topical retinoids you're going to see being used. Up next, we're going to have some of the antibiotics, and these are going to be ones that actually come as topical products, so they'll come as ointments or gels, things like that, creams most often. So we have things like clindamycin, which is good because clindamycin covers what? Anaerobes and gram-positives, right? So it's good as a topical product from that standpoint. Erythromycin, sulfacetamide, which is going to be kind of similar to the sulfamethoxazole, which we saw earlier in Bactrim, and the metronidazole can be used as well because metronidazole also covers anaerobes, right? So that's why you can see that being used very frequently. So again, just depends on again, things like cost, depends on intolerances, as far as which one you're going to use. Who can say which one actually works better than another? Again, you get such high concentrations with topically applied antibiotics that you don't have to really worry about resistance so much. Okay. Now, if topical treatment isn't enough, what do you do at that point? Well, now you have to start thinking about systemic products, okay? So one of the big ones we have is going to be the systemic retinoids, and this is where we have isotretinoin, otherwise known as Accutane, okay? Accutane is a very effective drug for acne. It is very intolerable in a lot of cases based on side effects. The other big thing is a pain in the butt to get, because this is a terrible, terrible teratogen. And in fact, they want to really make sure that there's no chance that a fetus is going to be affected by Accutane. Okay, so this is the first example we have of something that undergoes what we call a REMS program, R-E-M-S. That stands for Risk Evaluation and Mitigation Strategies. These are things that drug companies will do for drugs that have a very particular side effect or can be very dangerous or deadly for certain conditions or certain patients, that they will put a special program in place to make sure that the provider is trained up on it and knows how to do it and is registered. The pharmacy is registered with the program as well to make sure they can dispense it, and the patient has to be registered with it. There's a lot of paperwork that goes into it, but for patients that failed everything else, Accutane can be a lifesaver essentially for them. Not literally, but it can be something that can be very effective for them. Okay. Because the teratogenicity of it, right, so that means it's damaging the fetus essentially, is so bad that we don't want any chance that a patient will be pregnant with this, okay? So that means that when a patient signs up for it, that they have to have negative pregnancy tests are being documented on a regular basis. They have to make sure they're registered with the program, just like the doc and the provider and the pharmacist will have to be. And in fact, they worry about men also being affecting a potential female because they could potentially spread it in the semen. So because of that, even men are having to be registered with this as well to make sure they are educated, to make sure they're using prophylaxis and things like that. Okay, so again, male and female patients are affected by this. Okay, again, very serious teratogen. You got to be very careful. The program is called iPledge, and so that's something you have to register with if you worked in derm regularly, writing for this drug here. Okay. Anyway, some of the adverse reactions you're going to see with this, again, systemically you're thinking about it, not just where you're applying it, but systemic, because this is an oral tablet essentially. You're going to see a lot of erythema, a lot of pruritus, a lot of skin drying sort of effects. And again, this can really dry out the skin very significantly. It can be much more irritating to the patient than just the acne was from just a visible sort of standpoint. See things like photophobia, see things like arthralgias, even like the hair can start to fall out a little bit. You can get more brittle nails because again you're affecting vitamin A, which is very important for synthesis of nails and hair and things like that. It can affect your lipids. You can actually increase serum lipids in those cases. And again, you're like, man, all these side effects, why in the heck are we going to use it? It's really for those more severe cases where patients have failed everything else essentially, right? So again, it's a pain in the butt to get all the paperwork, a lot of side effects, but very effective for treating that acne. So if you have a patient with very severe acne, it's failed other product, this is the drug for them, and in some cases. And in fact, even signs of developing depression, right? So again, this can actually worsen depression in some patients, or maybe they develop it when they may have not had it before potentially. So you have to monitor for signs like that, any new feelings of hopelessness and not liking things you used to like, things like that are questions you want to ask these patients. Anyway, we can also use systemic antibiotics. Again, this is going to be more for extensive, difficult to treat disease here. Tetracyclines typically are going to be the first line therapy for these because again, they have good anaerobic coverage. They'll cover that P. acnes pretty significantly. But again, who do we not use this in? Yeah, so especially second or third trimester, we're not going to use it in pregnant patients, and then also, less than 8 years old, right? So again, probably okay because again, if they're already hitting puberty, they're probably not going to be at really risk for that. So again, you can see this used in a lot of teenagers. Would not use it in those kids less than 8 though, right? But tetracyclines get used very frequently. Tetracycline, doxycycline, minnow, any of those are fine. Very safe and effective, pretty inexpensive as well for the most part. They're very old drugs. Occasionally you'll use something like trimethoprim, sulfacetamide. Not used as frequently, though really the tetracyclines are the most common ones. Okay, so other things we can use potentially, things like salicylic acid. Anyone know what salicylic acid is? It's basically aspirin. Yeah, so acetylsalicylic acid is aspirin. Salicylic acid falls in the same category. This is actually used as a keratinolytic. So if you ever, you also use this for like things like wart removal as well, because it actually will help to break down that abnormally keratinized skin there. So that can be used potentially. Also has some mild anti-inflammatory activity. A lot of these are available over the counter as well, so patients may have tried these before coming in. In some cases, if the androgens are the problem, they have too much testosterone, too much DHT, sometimes we'll use anti-androgens. They can actually block those effects. There's a drug called spironolactone. We're going to talk a lot more about that when we get into talking about treatment of hypertension systemically, but it may be used as a gel potentially for some of those patients. Again, I'm just kind of letting you know what else is out there that you may use with some regularity, maybe not. And as I mentioned, oral contraceptives can be useful for some women. Other women, it may actually worsen their acne. So it just really depends on which ones you're using. The most common things you'll run into include ethinyl estradiol, which is a synthetic estrogen, and then usually some sort of progestin like norethindrone, something like that, levonorgestrel. When we get into talking about women's health, we'll get into all those different progesterones and how they interact differently with different receptors. So don't worry so much about that. Just know that some people do use that for acne treatment. In some cases, if you have really large, very inflammatory nodules, we'll sometimes use intralesional steroids. This is actually an injection in the office done right to the lesion itself. Again, some systemic absorption can occur, but you're going to typically find this is not done very frequently. Usually they're limited to how many times they can do this in a year, but you can see some local tissue atrophy, just like we would see with the topical steroids earlier, right? And then as I mentioned, oral corticosteroids can be used. This is better for flare-ups. You could give them a little, like maybe a week's worth of the steroids, and then you would taper them off onto something else, right? So again, these are good for kind of brief exacerbations there. Okay. So looking at how to actually treat this, and again, this is basically I'm trying to illustrate, this is a stepwise approach, right? So again, you're deciding based initially on the presentation how bad the acne is, on what agents you're going to use, and then you're just kind of stepping up from there based on how they're responding to the therapy, right? So for instance, they come in, and let's say for instance they have this sort of type 1 acne, where it's mainly some comedones, maybe some small inflamed ones, but really not too severe. They'll give you suggested options for treating, right? So we can use a lot of topical products, and in general, you start topically, and then you go systemic if you need to. Right, or if it's very diffuse, then you can go systemic. But typically, you start topically and go from there. So again, benzoyl peroxide, topical retinoids, those are good things to start with. If those were to fail, then you're going to step up therapy, right? So this is where we're going to start to think about things like your topical retinoids plus, right? So instead of either or, you'd use a combination of the two, right? This is where you can also start to think about topical antibiotics, right? If those fail, then what do you do? Well, then you start to think about more systemic utilization, right? So this is where you start thinking about adding on a tetracycline. Right, they're thinking about something like doxycycline or something orally in order to be, from a systemic standpoint, treat that. So it depends on which one you get. So if you just get tretinoin, that's going to be incompatible. The benzoyl peroxide will inactivate it. But if you were to use something like adapalene or something, that actually was able to be stable with that. And sometimes you may find like, okay, use benzoyl peroxide in the morning, use the tretinoin at night. Maybe vice versa, because again that one is more photolabile, so that was one you want to use at nighttime anyway. Sometimes that way you can use it in combination and they're not interfering with one another. Okay, so things like that you have to consider. And again, once they've kind of failed topical and systemic therapies, that's when you want to start thinking about the systemic retinoid, right? It's where you're going to start thinking about the Accutane being used there. If they failed a lot of other therapies, you don't want to jump to Accutane first because, again, there's so many side effects, such a pain in order to get the drug in the first place. Okay, kind of make sense? And again, things like anti-androgens, intralesional steroids, that's going to be much more on a case-by-case basis. And again, I wouldn't ask you specifically, which patient should get intralesional steroid. Like, if I did ask that, it'd be something like, patient has a large inflammatory nodule. I could make it very clear that's what that's for. But again, focus on the bread and butter stuff, like start topical, again, start low concentration, gradually increase, give it 1 to 2 months to see how it's going to work, and then go from there, right? All right. Anyway, a couple other conditions you may see from a dermatologic standpoint, things like acne rosacea. This is kind of interesting where they get these kind of burning, stinging, flushing sensation, typically located around the cheeks, the nose, etc. You're going to find that they have no comedones here. You're going to find the age of the patients typically differs pretty greatly here, usually age 30 to 50 versus teenagers you see more often with acne. And then typically affects more women than men. And it has certain triggers associated with, like hot liquids, alcohol, things like that. It's interesting here, the way we treat this, because we see this vasodilation, what we can actually use is a vasoconstrictor. So we have a drug called brimonidine, and this is actually going to come up when we talk about ophtho at some point. We're going to find this actually works as a vasoconstrictor to squeeze down those blood vessels, and we'll deal with that erythema that's actually happening there. We'll deal with that flushing sensation they're going to see with that. Occasionally may use some antibiotics, things like topical metronidazole, potentially. Occasionally use some systemic antibiotic, but for the most part, that brimonidine is going to be pretty good for most patients. And if you need some steroid antibiotics as well, that can also be useful there. Occasionally, you may have to use up something like azelaic acid. This is actually a new product, a more concentrated form that's available. But again, just know these are kind of treatment options for rosacea.
I was always kind of confused why would you use Metrogel for this?
Well, there could still be there's less of the P. acnes that's involved here, but it could still be somewhat present, right? So you still find that those bugs are there. So by using Metrogel, that can actually help to deal with that. Because again, when you think of that inflammation, you think about vasodilation, trying to bring all those inflammatory cytokines and immune cells and things like that to the area. So if you eliminate that bacterial origin, then hopefully you can deal with that inflammation, that vasodilation that's occurring there. That's my reasoning, at least.
Okay.
Yeah. But you bought it, though, right? If you sound confident enough,
Exactly.
you can make anyone believe anything.
I didn't know if it was one of those things. It was kind of just like somebody tried it one day and they're like, "Oh, it works. Cool. Don't know why, but."
Yeah. So sometimes we see that. Like for instance, Rogaine originally was an antihypertensive, and they realized, oh, these patients are growing all this hair. Cool. Let's use that on the top of their head and see.
Yeah.
There you go. Rest is history, right? Okay. Finally, finishing up, I have some lice infections. So again, if you don't have any itches or anything like that. So again, looking at things like body lice or scabies, you're going to see there's certain drugs we can use. Now again, we want to make sure when we're treating these little critters that we're going to use something that's going to be more specific for killing them than for dealing damage to us, right? And so we're going to see that actually some of these are pesticides basically. You may see these being used either as things to kill bugs in your home, or potentially like on an agricultural basis. You're going to see there's some crossover here. And of course, head lice are going to be a big problem, especially in children, especially if there are, depending on hygiene and depending on environment and things like that, it's going to be a big problem. You're going to find that a lot of these are going to be treated generally the same as far as from a drug standpoint. Now, things we're going to be using typically are going to be permethrins, and again, you're actually going to find permethrins in a lot of home-based pesticides you may use for just killing cockroaches and ants or whatever. Basically, what these do, they act as paralytics for the insect. So they'll paralyze the insect. The insect will then die from that, but will not affect us, right? Unless it's a very high concentration or something like that. But we're going to be giving enough. And again, these are topical products we can apply to the areas wherever the bugs are to try to kill them off that way.
It's just a paralytic agent, won't the bug wake up later?
Well, you paralyze them long enough to where they are going to eventually, they're not going to be oxygenating, and eventually they'll die out. They'll die before the drug wear off, essentially, right? I give you a paralytic right now, and you'll die before that paralytic wears off, So. Same thing for the bugs. Are you just pantomiming?
Dying slowly.
Oh, he wouldn't be able to move. He'd just be like, and he'd die, right? There you go. But actually, by blocking sodium channel, that's how we induce anesthesia or certain forms of anesthesia. So, for instance, like if I inject lidocaine into a patient and cause anesthesia, that's basically like numbing up those nerves essentially by blocking the sodium channel influx. If I were to do that to a wide enough scale, you could also do that to things like the skeletal muscle. The diaphragm could become paralyzed. That's essentially what we're doing to the bugs, right? It's just we have different enough targets where the permethrins don't really affect us nearly as much as it affects the insects, right? Which is good. So things like Nix cream is a big one that you use pretty frequently. Again, this is available over the counter for home use. Typically, when you're looking at these, you want to make sure they're not using a lot of repeated dosing, especially in small kids. As I mentioned, kids typically have a more underdeveloped stratum corneum. They absorb things better, and so they keep treating over and over and over again. That's where you're going to find that they tend to be more likely to develop some of these systemic toxicities, right? Especially if it's something like head lice, and they keep getting exposed to other kids with head lice. Guess what? They're going to come back potentially. These are things to consider. So again, permethrin or Nix cream is a common one. We have things like piperonal butoxide. Again, this is just another form of a permethrin there. Actually, and then for even more severe cases, you can actually use kind of more potentially dangerous agents, but they're low enough concentration, really shouldn't be an issue. This one's called malathion. This is actually what we call a organophosphate. And so if you ever take a tox course, you'll learn all about organophosphates. But these typically are going to be a little bit more dangerous. You want to be very careful and use these as more like refractory cases. I don't want to get into all the details. We don't really have time. But just know that typically you start with like a permethrin, and then you kind of work your way up depending on how resistant the bugs have become. Because again, they can develop mutations that make them resistant to some of these as well, right? Ivermectin is the one. If you ever deal with animals, you probably see giving ivermectin for them for like deworming and things like that. But this can also be useful for head lice for treating that. And again, potentially the big thing with head lice is the problem is not just the bugs, but also what else is in the head or on the head. The nits, right? So it's all the eggs that actually attach to the hair follicles as well. So again, it's important to make sure you try to get rid of those. That's why you oftentimes will see nit combs associated with those, to try to comb those out to get rid of them. But also you can use things like formic acid that doesn't actually kill the insects, but will actually be able to help loosen up those eggs. That way you can help comb them out a little bit easier. Other things, you have things like Clindamycin. This is good for treatment of scabies. We don't know the mechanism, but it's also good as an antipruritic, so it's going to help with the itching that happens with a lot of these infestations here. And again, helps killing the bug and helping with the itch. And for pubic lice, we have another one called Lindane. This is actually going to be one that, again, be very careful with repeat uses. This is a big one that I see, and sometimes this will be used for head lice as well. But I see parents want to use like multiple courses of it because, again, the head lice keep coming back. This can actually lead to seizures. So that's one of the kind of unique side effects with Lindane. Be careful with it causing seizures there. Usually comes as a shampoo for head lice. But again, we like to use this as a backup if kind of the other stuff has already failed. So again, not a first-line agent there. And then for warts, we also have several different agents we have available. And again, warts are typically caused by what? Right, so usually caused by a virus, and you're going to find that we can't really get rid of the virus itself, but what we can do is deal with that abnormal keratinization. So usually you're going to find we use a lot of keratinolytics. Does anyone know what a good over-the-counter, you wouldn't find it at the pharmacy sort of agent you can use for warts? Duct tape, yeah, duct tape is actually, I did a talk one time on home remedies, and actually found that duct tape was just as good as any of the home products you can use for treatment of warts. Basically just kind of leave it on there, it gets really attached, and then take it off. And repeated courses kind of helps with that. But anyway, yeah, duct tape can be very good for that. But basically when we're using drug products, they're typically trying to be used as a keratinolytic. This is where we see the salicylic acid comes up again. It helps to kind of break down that skin and eventually kind of get rid of it. In some cases, we'll talk about, freezing is obviously another good tactic there. We won't really talk about it here because it's not necessarily a drug product necessarily. It's just more of like kind of a temperature sort of therapy. There are a couple different things you can use called podophyllin. This is actually good for things like anogenital warts. These are going to be better for trying to help actually treat the virus itself. But like things like Podophylax can be used here. Again, not recommended for over-the-counter use, not really available for them. Be used more in the office in a lot of cases there. We have this one called Imiquimod or Aldera. This can also be very effective than Podophyllum, more so than Podophyllum. Can be a little bit safer, especially like in pregnant women as well. Something to think about. The biggest thing though is to make sure you try to not get HPV in the first place. So that's why we talk about immunizations, and Gardasil is going to be a big one, right? So again, not only does Gardasil cover against, hopefully, it doesn't cover all strains of HPV. The one we use now actually covers 9 different varieties, but the big ones that it does cover are the ones that actually cause cervical cancer in women, right? So again, does that mean only women get Gardasil? No, because who can spread it to women? Men, right? So boys and girls should get that. My girls are definitely getting it whenever they're of age. Yes, ma'am.
What is pregnancy?
Oh, so that's just something about pregnancy categories. We'll talk more about that a little bit later. But just, again, I'm not going to quiz you on that specifically on the test. It's just kind of some more kind of for your information. But yes, pregnancy categories are important. You always want to make sure you check if your patient is pregnant or may become pregnant. Check on those. Make sure you're not giving them something that's going to be bad, right? Mm-hmm. And again, I mentioned Imiquimod. This is actually interesting because it's actually working as an immunomodulator, meaning it actually stimulates the host immune system to actually start attacking the site of the wart, attack some of those viruses there. So it can be pretty useful, pretty safe for the most part. But again, this is going to cause a lot of skin irritation in patients. It may actually seem like their symptoms are getting worse rather than better, but it can be very useful. Okay, so I'm sorry that was a little quick. I want to make sure we got done. I'm making the executive decision that just read the opto slides and you'll be fine for the test. No, I'm just kidding. I'm not going to do that. No, that'd be pretty mean. I could make you watch a video. I could just record something and make you watch it, but I feel like the test being on Thursday, it's a little bit of a short turnaround time. I'm going to push that, right? So I'm going to go and revise the test. That's good and bad, right? So one, you have less material to cover for the test, right? So now you're just doing the dermatology stuff and all the antibiotics. The bad thing is that means that I'm only covering the antibiotics and the derm stuff. So it means I can get more in depth on those things, covering less material, but I can go deeper than if I were to try and fit in some opto stuff in there as well, okay? Double-edged sword. Oh, you guys are okay with that?
I guess.
It is what it is, and I make the executive decision anyway, so. Yes, ma'am. Yes, I'm going to have to push that off onto the next test. We'll see how it works out. But and again, everything is subject to change. One of the big things in medicine is you got to be flexible, go with the flow. You know, yeah, I think this will be best for everyone. So the material ends through derm. Opto is going to get pushed. Okay, so that's the final word. Yes, ma'am. 50 questions, 5 answer choices, just like normal. I'm not sure what time limit they give you guys on these for this semester. I don't know, whatever time limit they give you is what you got. I told them 30 minutes, but they wouldn't listen to me, so, you know. Just kidding. Okay, so I'm going to work on the quizzes. I'll give you some feedback on that to let you know how they are. Don't forget about your prescription assignments. Get those turned in. That should also be due the day of the test, I believe. Is that correct? Yep. So get those done. If you have any questions, please email me. I'll try to be receptive, but if you email me Wednesday night, 2 in the morning, I'm not going to get back to you. Just how it is, right? Yes, ma'am.
I know you said you're going to put like feedback up by Monday.
Yeah.
Like, what are the first words you're going to be able to do?
As soon as I give you feedback, that it should be inputted. Yeah. Yeah, it'll all be done at once. Yep. Okay, thanks.